will be moderated by Louise Tillin, and the second session will then examine, what this means for India. So we have two discussants, Nachiket and Yamini, and we will do the detailed introductions later. So I'm going to request my co-host, co-moderator, Louise Tillin today, who's the director of King's India Institute, to take it from here and moderate the first session. A very, very warm welcome once again to it.
Thank you very much, Sandhya, and from my side too, a very warm welcome to the audience and to our distinguished panel today. As Sandhya said, my name is Louise Tillin. I am the director of the King's India Institute at King's College London, a reader in politics, and it really is a pleasure for the King's India Institute to be co-hosting this discussion on one of the most crucial questions facing India, not least as it transitions through the COVID pandemic, but also as it moves ahead on its path towards universalization of health. So it is my task to moderate the first panel. We are expecting one more speaker, but I will rejig the order because, to accommodate his timing. So to introduce our speakers, first of all, we have Professor Rifat Atun, Professor of Global Health Systems at the Harvard T.H. Chan School of Public Health at Harvard University. Professor Atun has worked with more than 30 governments across the world, as well as the World Bank, World Health Organization, the UK Department for International Development, to design, implement and evaluate health system reform initiatives. And he'll be speaking to us today about the politics of health reforms in Turkey. After Professor Atun, I will invite Dr. Viroj Tangcharoensathien, who is a senior advisor at the International Health Policy Programme of the Ministry of Public Health in Thailand. Viroj trained in medicine and I understand received the accolade of being the best rural doctor from the Thai Medical Association in 1986. He went on to receive a PhD in health planning and financing at the London School of Hygiene and Tropical Medicine, and he is closely involved with the Thai government's public health programme. And he'll be talking to us today, unsurprisingly, about the politics of health universalisation in Thailand. I hope that lastly we will be joined by José Antonio Gonzalez Anaya, who is a former finance minister in Mexico in 2017 to 2018. Prior to his tenure as finance minister, he was firstly CEO of the petroleum company Pemex, and before that, general director of the Mexican Social Security Institute, during which time he was closely involved in Mexico's health sector reforms. And he holds a PhD in economics from Harvard. So I'll turn first to Rifat Atun and invite you to offer your reflections on the politics of health reforms in Turkey.
Great. Thank you very much indeed for inviting me to contribute to this very interesting and very timely panel. I will not use slides, but I will speak freely. To share with you the experience of major transformational health reforms in Turkey. And I'm saying this in the beginning because I think it's very important to understand the extent, both the scale and the scope of the reforms that were undertaken by the then Turkish government, and explore what made this possible, and what made it successful, and also explore some of the lessons learned, as well as some of the challenges that remain. But first, the study that we analyze this in great detail, and this was published as a paper in The Lancet in 2013. We analyze both the antecedents of the reforms themselves, as well as the effects of the reforms in terms of coverage and outcomes, and I'll talk about those in turn. But first of all, I'd like to say something about the politics of reform. I think it's very important to explore sort of the political determinants, but I want to leave you with a sort of important caveat in the beginning that alone is not enough. I feel over the years, what I've seen is that just narrowly focusing on political determinants is far too narrow a lens to analyze what I call the receptivity of the context for reforms, introduction of reforms, and the scale up of reforms. So I would suggest that the political analysis is part of a broader analysis of the context that is ever changing and that is so critically important in countries like Turkey, Mexico, Thailand, India, where the context is changing very, very rapidly. And by that, I mean the changes in the demography, the demographic structure of the population, the changes in the epidemiological profile of the country, the changes in the political environment, changes in the legal and regulatory environment. And by that, I mean not just health policies, but actually the legal treaties and agreements, regional agreements that countries enter into that may enable or hinder reforms or provide an impetus for reforms. As well as the changes in the socioeconomic norms and expectations of citizens, critically important, changes in the ecology, changes in the technology, and very important, the changes in the economic environment. Now, in order to undertake transformational reforms, as they say, all the stars need to be aligned, or many of these stars in the context need to be aligned to provide an enabling or a receptive context for the reforms to come onto the policy agenda and to translate these policies into action. And it's very important in the case of Turkey, because just looking at the antecedents, we see a country, so the reforms began in 2003, but in the run-up to the 2003, for the 20 years preceding that, so-called the lost decades, the 20 years of coalition governments, where health reforms were on the policy agenda, but it was not possible, even though the white papers were written for the laws, the parliament could not enact these. So as a result, it was not possible to enact the reforms, even though this was an important issue for many governments in the 1980s and 1990s. As a result of this lack of implementation and having the ability to introduce new legislation to transform the system, Turkey enters sort of 2003 elections with inadequate and inequitable financing of the health system, with absolute shortages of key resources such as physical infrastructure, as well as human resources, and as a result, inequities in the coverage, especially effective coverage, and also in inequities in outcomes, particularly under 5 mortality, infant mortality, maternal mortality. And see a huge disparities between the East and Southeast and the West, so-called the industrial part of Turkey and around Istanbul, the wealthiest parts of the country, where the coverage levels could vary by 2-fold or 3-fold, as would outcomes. Now, on top of this period of inequalities, Turkey, before the elections, experienced a huge shock. There was an earthquake in Marmara region of Turkey in the West. And there the government as a whole was not able to respond to this earthquake. As a result, thousands of people died, and the response was very late. There was a lot of bickering, and citizens they were just fed up. They said, okay, these governments are not able to do anything. Then comes the elections, a new party with a strong message to improve citizenship and improve economic well-being of the country, where the inflation had been very high, where the economic growth had been faltering, and to invest in health as a priority area. But universal health coverage had been on the policy agenda for many, many years, actually sort of since 1945, with the establishment of the Social Insurance Organization. That was followed by extension of this for civil servants in 1949. And then there was a first national health plan in 1954. This was followed by the very important law on socialization of health that aimed to universalize healthcare and coverage. And then there was establishment of the insurance organization for artisans and those in sort of part-time, those in self-employed and small businesses. And in the 1990s, early 1990, the new constitution stressed the state of the role of the state in universal health coverage, which was followed by a green card scheme that provided, in design, but not in effect, non-contributory scheme for the poorer segments of the population, those households below a certain income level. But unfortunately, what this led to was a segmented system or a stratified system with 4 parallel systems with very good benefits for the retired civil servants, followed by the blue-collar workers, then artisans, and for small businesses. But the green card scheme targeting the poorer segments of the population never really functioned. So as we enter the elections, there's a very strong momentum for change and for citizenship. And health is framed as part of this narrative by this new party, that health is part of the citizenship, it's a right, and the role of the Minister of Health is to protect the citizens and address the asymmetries and the imbalances, and to overcome the inequalities that exist. Now, this is important politically because the power base or the electoral base of the AK party was actually in the south, in the central Turkey, Anatolia, in the east, and also southeast. And this is the areas where improvement was needed. So the government actually embarked upon a very ambitious health reform program. It was a risky strategy, but if it worked, it would have actually benefited the government. So that was the thinking. So the reforms were introduced. Actually, Viroj was one of the conversations we were having with the Minister of Health at the time. And I remember Viroj describing the Thai experience. And I sensed the minister at the time saying that we really don't have time. We have to move very quickly. We want to introduce the reforms within a few years to see the results. So there was a very strong focus on not just introducing the reforms, but actually reaping the benefits to gain further political capital in order to sustain the reforms, but very importantly, sustain the government. So the transformation program was designed not just for improvements in health outcomes, but also to really strengthen the support of the electoral base and to gain further support for this new political party, which won an unprecedented sort of majority and was able to form a government, not a coalition government, but a government, a majority government. And the transformation program that was implemented was very interesting in that not only was it comprehensive, the strategy was really informed by evidence and global experience. There was continuous monitoring and learning, was very flexible in implementation, a strategy, but with tactical changes, with a loss of listening to the citizens and to the populations to try and meet their needs, to try and address what I said in the context, the expectations of the society at that point in time. It was also designed to address the economic inequalities by providing a sort of conditional cash transfers to the poorer segments. And big emphasis was on leveling the benefits. And strengthening the green card scheme, which had not been functioning. And there was a very big emphasis on rapid expansion of primary healthcare and community-based healthcare to expand coverage, especially for the segments of the population where care had not been very effective. So just to give you some examples, so in 2003, of the 5 major public services, health was the worst performing, with satisfaction levels below 40%. In terms of insurance coverage, again, there were huge inequalities. So those covered by the non-contributory green card scheme, the coverage level was 20% in the poorest decile, whereas in the richest decile, the coverage was around 90%, and a very clear gradient between the poorest decile and the richest decile. So that was in 2003. And the distribution of the resources, we can see a real dearth of health professionals in the South and Southeast, where there had also been some sort of civil unrest. It was difficult to attract people, but also to retain them. So the priority was of the government was to rapidly scale up. And the government did that by actually using novel approaches, using outsourcing and creating a new family medicine model where the family health teams were contracted, because the whole bureaucratic process of actually appointing new health workers, but also giving them performance-related pay would have been very complicated. So flexible instruments were used to achieve rapid expansion and improve distribution to rural areas. So whereas between 1993 and 2002, the number of people working in the health professions working in the health system only changed from 2024 to 2056. By 2012, after the election, just within nine years, the number had almost doubled to 510,000, and almost 130,000 of those health professionals were attracted through contracting. And then distribution changed and coverage improved, especially antenatal care, births attended by trained staff. We see a sharp fall in also immunization levels improved, and we see a convergence, whereas there was a big difference between rural and urban areas, between income groups with different income quintiles or different education levels, 3-4-fold differences. We see sharp convergence after 5 years of introduction of reforms, where the underperforming groups reach those levels achieved by higher income groups, better educated groups, and urban groups. And we should also see a sharp decline in outcomes. So what happens? Well, as well as improvement in coverage, improvements in equity, there's also very important improvements in financial protection, where out-of-pocket expenditures fall, because the green card scheme, which was 20% in 2003, by 2011, that increases to cover almost 80% of the poorest households. And all the income groups improve, even the higher income groups. So we see rapid increase in financial entitlement, but very importantly, the supply side scale up happens. So that's a very important message for India. There's no point just having entitlement. Many countries have in their constitution, health is a right, health protection is a right, so on and so forth. But without supply side interventions and rapid scale up, the citizens will not benefit or will not see the benefits. And so this was the important change, with rapid change in the benefits, scaling up of all the benefits, so that the 4 or 5 different schemes were now unified and had a common benefits. So there was no difference between the green card scheme and the civil servants. And there was a rapid scale up of the family health teams as well as hospitals. So as a result, the satisfaction levels improved from less than 40% to reach about 75% by 2011. And this is at the same level as the best performing services. Now that gives, the rapid increase in scale up and the improved experience of the citizens provides the health ministry the legitimacy to introduce further reforms, and improves the importance of health within the broader government, such that the Minister of Health stayed in in his position for almost 10 years. That's completely unprecedented in the history of Turkey, where the ministers change almost every year, sometimes twice a year. This is ministers of health. So there's a sort of sustained effort and sustained improvement, which then provides the political support and electoral support to the government. And some say almost 15 to 19 percentage points of the electoral vote was because of improvements in health. So this is this is a very important story. But once you're successful, then that has to be sustained. What are the lessons learned? Well, first of all, there was a very receptive context for change. Everything was aligned. Health was positioned as a fundamental citizen's right. Economic growth was used as an opportunity to invest in health, and that enabled the enhanced role of the government. And there was sustained leadership and a transformation team put in place with flexible implementation to respond to citizens' needs, with careful sequencing of the changes and ongoing learning. And the reforms were implemented very speedily to prevent resistance, especially from professional groups. And very importantly, combine demand-side changes with supply-side changes. But of course, the agenda is not finished because citizens expect more. So the government has got to continue to sustain these benefits, which is fine when the economy is doing well. But now Turkey is experiencing economic difficulties. So the government is under pressure to sustain the very comprehensive benefits scheme that it has introduced. Also, after the introduction of family health medicine and improvements in community health medicine, there was a big investment in the hospital sector, which is consuming a large proportion of the budget. Now, in my view, obviously the government had its own reasons for that, but I think the money could have been better spent in further strengthening primary healthcare because it's very expensive to sustain these hospitals. There needs to be ongoing investment in quality and safety, but all of this requires the fiscal space to sustain the reforms and sustain the political support. So I'm going to stop there. It's a fascinating history, but universal health coverage took a long time. But when there was a political will and when everything was aligned in the context, it was possible to introduce transformational change.
Thank you very much, Rifat. That was fascinating. I'm going to turn now to invite Dr. Viroj Tangcharoensathien to speak about Thailand.
Thank you, Louise. Thank you, Sandhya. I just want to endorse what Rifat has said. Our experience is quite similar, but different contexts. We have achieved universal by 2002. And today we spent health expenditure was around less than 4% GDP. And our pocket payment is 11% of current health spending, which much lower than OECD average of 18%. So that de facto reflect very high level of financial risk protection and very low incidence of catastrophic spending and impoverishment from health spending. Government spending is around 16% of the annual government budget. Health has improved a lot. Under 5 deaths is 12 per 1,000 live birth. Skill birth is near 100%. So that means under 5 deaths is that low. I have been working as a participatory observer and also actors. Between 2001 and 2002, that USC was launched until today. We have 2 decades of experience. How many governments we have? We have 9 government, 9 prime minister in 20 years. And we have 15 health minister. So that we have a very political conflict, protracted conflict in the past 2 decades. But the USC has been thriving very well. It's amazing how it was not derailed by the opposition government. They take turn and they fight. Even today, we are in the middle of constitution amendment. So I work with at least 9 government after the launch of USC and work with 15 ministers. Even today, we have a good conversation with him on vaccine rollout. So what happened? I like to structure my talk into 3 areas. One is how the supply side, as Rifat has said. Without supply side, you lie your citizen. You lie your citizen that USC is right in the paper. That never comes through. Then we make service available since 70. Government has a sustainable investment in primary health care at a district health system consisting of district hospitals and sub-district health center for a catchment population of 5,000. So we have a decade of health center development. So in 10 years, we have scaled up to 100% geographical coverage of sub-district health center. And we have a decade of district health hospital development. So we build up, construct new hospitals in all 800 districts. So this is a strong platform for USC implementation. Without this, you don't talk about USC. We have a joint study with Indonesia, and the BPJS, which is the USC in Indonesia, has a pro-rich outcome because the supply side is so unequal across Java, which is a lot of internists, cardiac surgeon, etc., and nothing in Papua New Guinea, in Papua, which is a big island, a jungle island without health infrastructures. Therefore, a too premature early USC without a strong platform of supply side capacity is a premature movement. So we fixed this until full coverage of service in district, in sub-district, in province by the late 1990s. So that is on the supply side. Only infrastructure doesn't work. We need health workforce. Thailand has implemented well beyond the WHO guideline on what is effective on retention of health workforce in rural areas. We have financial incentive, mandatory 3-year rural services, and this batch of rural doctors become, in the past 40 years, 50 years, they become high-level policy maker in the MOH, as a permanent secretary, as a DG, etc. And the value laden in their mind, having experience working with the poor, with driving a pickup car and sending the diseased patient back home in the mid of the night. So that have a eyewitness of the pain, suffering, how the poor live in rural area. And this have a pro-poor ideological reformist bureaucrat. The term reformist bureaucrat is a scholar called Joseph Harris from Boston University, and he published a lot about the Thai political dimension of USC. And he termed this as a reformist bureaucrat. You can quote and search his article, Thai USC and Joe Harris. So that is on the supply side strengthening. On the financial risk protection and financial access, we gradually expand. We have low-income scheme for the poor in 1975. We have in 1982, we introduced a royal decree for civil servant medical benefit scheme, because government employee has received a very low income, low salary. Therefore, health benefit is a fringe benefit. In 1984, we introduced voluntary public health insurance. It's a premium contribution. And by 1994, I submit a proposal to the cabinet because health minister asked me to do something to increase the coverage. Then that voluntary premium finance scheme is become as a public subsidized. So that means 50% of the premium is subsidized by the government. And 1990, we have adopted a social security scheme. And I published in Indian journal called Economic and Political Weekly in 2012. I have introduced capitation payment for the social health insurance, the first ever, I think, in Asia. And many people ask me why you are stupid. You have to give liberty for your citizen to go elsewhere by fee-for service. I said capitation and primary care fund holder is one way to first ensure efficiency of using resources. Then I published a paper on how capitation was estimated. At that time, I involved and have been working in the MOH as a health planner, program budget director, and see that between 1970, 1890, 2000, it is a bureaucrat-led, technocrat-led Ministry of Health. And most of the minister at that time, the previous bureaucrat who have a equity laden value compared to, we don't have the system like IAS in India that you have, this is a professional, a civil servant, you have a transport minister become health minister, or transport health secretary become a health secretary. It is not the case in Thailand. Health secretary mostly come from within the health sector. Therefore, there is a continuity of wisdom, continuity of policy. By 2002, we have 30% of population are uninsured. Therefore, we think that the opportunity has come. I interviewed the then Prime Minister and the then Health Minister that if you won the election, will you introduce USC? From the Democrat Party, they are so conservative. They say no. We just ask the rich who can pay their own services, and we only catering the poor. And we talked to Thaksin Shinawatra and his group. He said, I will make it as a political manifesto in the 2001 general election. Therefore, that is the trigger. The question that Sandhya asked me to talk is the political determinant of reform or USC. I concur with Rifat that it is quite a narrow interpretation. It is a multifactorial. First, you need a supply side capacity. You need a faithful and good ethics, work ethics among health professionals. In Thailand, we do not have absenteeism. Of course, 40 years ago, when I was working in district hospital, we do have some absenteeism of teachers and doctors and nurses. But when gradually health system evolve, people demand more, and absenteeism become a history. Therefore, on the supply side, it is so critical that we have a good and decent quality, equitable distribute throughout the country on the supply side. Second, financial risk protection. I published a paper in Peter Townsend in 2009, and we define our USC trajectory as a targeting piecemeal approach, targeting the poor, targeting the civil servant, targeting the private sector employee, targeting the voluntary, the non-poor, informal sector by voluntary premium and later public subsidized scheme. And then the political window of opportunity come. Then we introduce USC, and that is so successful. Politics determine policy agenda. Of course, we agree with that notion. But come to a policy formulation, it requires wisdom. It requires capacity of the country to decide its own provider payment method, decide its own benefit package. The World Bank expert consultant told me that why you introduce capitation, you need to give liberty to your citizen to travel anywhere by free fall service. I told him, you go back home. Don't come my country. It's my own business. It's not your business. Therefore, Jim Kim said, Thailand introduced USC with against the will of and the advice by his consultant. World Bank want to publish a paper undermine our legitimate policy movement to USC. And I strongly talk to the World Bank resident coordinator in Bangkok that this is unacceptable. And then Jim Kim told me that he was regret that his consultant behaved that way. And we have shown the world that we can do it. And today the schemes thrive quite well because the governance is so strong. We have civil society, 5 seats out of 32 seats sitting in the governing body of the USC scheme. I'll stop there, Louise. Thank you.
Thank you ever so much, Viroj. I fear that we have not been joined by our third speaker on Mexico, which is a shame, but it does enable us to have a longer conversation about the implications for India of what we've just been hearing about Thailand and Turkey. So with that, I'm going to hand over to Sandhya to lead the next part of the discussion.
Thanks, Louise, and thank you so much, Dr. Viroj and Professor Atun. I don't know what happened to our speaker from Mexico because he just confirmed a couple of hours before. But anyway, I'm guessing some unforeseen happened. So our next session is, we have two excellent discussants. Having heard the journey of Turkey and Thailand, challenges that we're struggling with in India, and what might be some pathways going forward. So we have two discussants, Yamini Aiyar. Yamini is President and Chief Executive of Center for Policy Research, which is one of the premier think tanks in India. And she was previously the founder of Accountability Initiative, which, correct me if I'm wrong, Yamini, one of the pioneering initiatives on budget tracking. And it's the go-to place actually for budget tracking. Yamini's research focuses on multiple exciting issues like public finance, social policy, state capacity, federalism, governance, etc. It's a long list, and she's on many government and other task forces, boards, committees, so is inputting into policy discussions at very high levels. Nachiket is a visiting scientist at the Banyan Academy of Leadership in Mental Health, as well as a senior research fellow at the Center for Information Technology and Public Policy at IIT Bangalore. Nachiket was previously on the board of the Reserve Bank of India, and his research or his work currently focuses on looking at the design of health systems, both at national and subnational levels. He's also been on multiple task forces, committees, and the one that I will name is the one that was set up by the government of India, focusing on universal health coverage. And he's also been working with the state. So we couldn't have two better people to basically discuss India. I have 4 questions, and let's see if we have time for all 4 of them. If we can basically spend about 10 minutes for each question. Yamini, I'm going to begin with you. We heard Dr. Viroj talk about, in some ways, the social compact between the citizens and the government. He didn't mention too much today, but a previous conversation with him also talked about trust between the citizens and the government. And that, makes me wonder how, when we look at that and the role that played in terms of taking the reforms forward in Thailand, when we complement that with the electoral situation here, one of the things that often lamented is that, and I mentioned earlier as well, that health is not an electoral ask, is a possible reason for that, that the trust between citizen and the government is not very high, that the citizens are not confident that the government system is going to be able to deliver. And could it be a case that even our leaders are not confident of the system being able to deliver? I'm sort of really going out on a limb right now. So what does that say about India being able to prioritize health? The whole issue of trust and the social compact, how does that pan out? And is there a way to fix it if that is indeed a challenge?
Thank you. Thank you so much, Sandhya, Louise, and to everyone on this panel. This is such an important conversation, and it's been an absolute treat to listen and learn from the experiences of Turkey and Thailand. Thailand in particular gets presented as a sort of gold standard of UHC, and many conversations we've had in India about UHC and what pathways we ought to tread to get to UHC. And so it's really been a wonderful treat to listen and learn, because one hears so much about it, but doesn't get a good enough understanding of the complex dynamics through which those goals were achieved. And I think, so there, a lot of what we heard both from Turkey and Thailand, and the issue that you lay out of trust, even though it perhaps was not articulated as such, really gets to the heart of the problem. Because I think in both cases, both speakers emphasize that a UHC is not just an entitlement. It's not just about a right. It's also about building the supply side capability, and I'm going to use the word capability, not capacity, and I'll come back to that in a moment, in order to be able to ensure that those entitlements are actually fulfilled, so we do not end up with hollow rights. And I think that's we can call it supply side, but it's essentially at the heart of what frames the social compact, which is trust. When you build and demonstrate the capability of the system, inevitably political demand will emerge. So let's now look at where we are in India today. Last year, in the early days of COVID crisis, so this was literally July of last year, a group of colleagues at the Center for Policy Research were working with the government, with the state government, trying to figure out what would be the most effective mechanism to expand and scale up testing in a way that, because with COVID testing, if you want to use COVID testing as a tool to get a better understanding of disease dynamics or transmission dynamics, you're essentially at some level looking, it's a needle in a haystack. And at that point, testing was not so widely available, so it wasn't really demand driven. It was much more supply driven through the state. And we piloted just a small survey in a peri-urban part of the state, where local block level officers were essentially did a surveillance survey and then handed out free vouchers to citizens who participated in the survey to go out and go to a testing facility to undertake a test. We surveyed, if I'm not wrong, more than 400 households. Only about 4 actually showed up for this free test. Sorry, I'm getting a hollow. Yeah, sorry, there was a hollow sound, which is a bit distracting. To some of our colleagues, that was a surprise. And the conversation with government was particularly interesting because, from government's point of view, the whole pilot was a complete failure because they were out looking to see if we would be able to find correlates to where there would be potential of COVID. And there was no question of finding correlates because nobody actually showed up to get tested. For us, this was a really important insight into understanding how the citizenry was viewing the role of government in COVID. But that was not seen as relevant. What the government was looking at targets, we have to test X number, we have to figure out where the disease is spreading, and then we have to start identifying containment zones. So sort of, at that point, the language was very much about testing, containment, lockdowns. And in the course of, we sort of pushed them a little bit further to say, let's find ways of trying to encourage people to come to test. And then a lot more investment was made in actually working with community mobilizers, and funnily enough, even block level election officers going house to house, having dialogues and conversations, both to understand why people were hesitant to test, and through that process, encourage people to test. That had some limited amount of success. More people showed up to test. But what it also did tell us is that once government actually goes out to start trying to understand what are constraints to people's response to the health system, you suddenly actually get to the heart of trust. People did not believe that if they went to, because the state is viewed as an instrument of coercive power. So the minute the state was saying come to test, there was deep fear at that point in time that would mean we would end up in a containment zone, we have to go to an isolation center, our livelihoods would get would be stalled, and that would have significant economic consequences. Citizens were acting rationally in response to a coercive state, and also in response to a state that it doesn't actually have any visible understanding of ever having provided high quality health. So when citizens actually want to go to get health services, and we know this from Jishnu Das and others' work, they don't actually go to the government MBBS doctor that is often available in limited supply, but available nonetheless in parts of rural India. They most often go to the informal health workers. Again, government, our sort of supply side response to this has always been in the grammar of failure of government at one level, but also failure of the citizenry in forging a compact with the state. When the state provides the doctor, hold the doctor accountable for showing up, for providing quality care. And citizens are saying, actually, I don't trust that you'll do it. So I'm going to go to whatever context where I feel I will be treated in a way that will give me a certain kind of treatment. We may call that a consequence of information asymmetries or ignorance, as some might say, but this is about a certain kind of behavior. So I think part of where the trust breakdown narrative starts becoming important is that both when we talk about supply side responses to healthcare, we don't really understand who the client is, to use that kind of language. And in fact, we often dismiss the perspective and the ways in which people seek healthcare. It's not like people don't seek healthcare. They do. When you fall sick, you have to go somewhere to seek treatment. What we need to understand is where it is that they go and what it is that what is it that moves people in that direction. Once you start building a response that actually builds that understanding in, that's when trust starts building. And ultimately, I think that our speakers from Turkey and Thailand are absolutely right. And we need to understand that the great puzzle of Indian democracy, how is it that we have such a vibrant democracy where welfare is very much part of the political narrative? I think Louise's work speaks to that so very powerfully. It's not like citizens don't demand of the state. And it's not that states don't respond. But the puzzle always has been, why do health and education not come up at the heart of this debate? I think in education, it's a bit clearer in some sense, in some ways, because the political economy of education seems to suggest people want to send their children to school, but they don't trust the state, so they'll look for private schooling as much as they can. In health, it gets much more complex. And I think that demand is not coming because people are seeking healthcare outside of the state with absolutely very limited expectation of the state providing health. And when people go to the state to seek care, or when the state asks people to seek care, it's usually done in a framework of state coercion, which essentially creates disincentives for that demand. And I think COVID has been a really, really good example, at least in India. I think across the world, coercive measures were used to deal and continue to be used to address COVID. And there is something to be debated about what is the relationship between coercion and public health, because obviously there are externalities and state coercion may well be necessary. But in India, it became very much about framing a health problem in the context of law and order, which deepens the distrust rather than responds to it at a time when the state was such an essential actor in responding. So I think that trust, to close, trust is at the heart of the social compact. Trust is broken, therefore the social compact is broken. And in some senses today, the onus lies on the state to demonstrate its capability before the citizenry starts demanding. And therefore perhaps the question that we've all been grappling with, why is health not a burning political issue in a vibrant democracy, or at least in an electoral democracy where elections are hotly contested across a whole range of issues? Perhaps we need to turn that question on its head and ask, why is it that politicians don't seek political legitimacy through demonstrating that the health system can actually work? In order to be able to bridge the trust gap and then build a more robust conversation on what it means to reach the goal of UHC.
Thank you, Yamini.
Hello, Sandhya, I think you can hear me.
Yes, yes. That's what I want to say. Welcome, Jose Antonio. Could everybody please microphone? So,
Jose, could I invite you just to turn off your microphone for a minute, because it's causing some feedback.
Lovely, thank you. So I want to thanks Yamini, and I want to welcome Jose Antonio from Mexico, who's just joined us. He's as Louise had already introduced him, a former Minister of Finance from Mexico and the Director General of the Social Security institution there. Jose, we had actually started off, there was obviously some confusion, and my apologies for that, but so glad that we have you here now. And as we were discussing the whole issue of trust and social compact, and Yamini, you mentioned coercion, I'm wondering to what extent state capacity also plays a role, influences the trust, deliver as per, let's say, my expectations. That is going to influence my trust and whether I go back to that service or whether I go elsewhere. And that's where I'd like to get you in, Jose, and talk about the experiences from Mexico in terms of what really motivated the reforms and what role did state capacity and what role did...
I think that Sandhya is experiencing some internet problems. The rains in Delhi.
The social compact between citizens and the Mexican government play in initiating the reforms. Over to you. Oh, it wasn't clear what I said? Was it not clear what I said? Should I?
Sandhya, I think we probably got enough. Maybe we could invite Jose now to speak.
Okay, thank you. I hope you can hear me well.
Yeah.
1 second.
Jose, Antonio, maybe request you.
1 second. 1 second.
You should be having some technical problems.
Yeah, I think you can hear me now.
Yes, that's much better.
I am sorry, I was logged in twice. I have heard everyone's presentation, I was logged in from the beginning, but I logged in, I guess, as an attendant and not as a panelist. When you called on me, I was saying, I'm here, but I wasn't here. So I have heard the discussion. Thank you very much for the invitation. I was logged in twice, so that's why I was making an echo. Let me make some quick remarks since I had technical difficulties. The experiences of Turkey and Thailand, and to some degree India, were familiar to me when I was heading the Health Institute, because we were trying to see how these countries who were before the Mexican latest round of health reform approached it. I have some general topics to say. One is that one cannot start from zero. When you're in a country, the temptation is to think of the ideal health care delivery service and try to implant it like that and try to ignore where you are. And that you can't do, in my humble opinion, and the political economy of trying to do that, which from my humble experience has been a common mistake in Mexico, which is to try to jump into the to the NHS sort of solution where everything works, doesn't really work. And to do that, I think the lesson is you construct your healthcare delivery services little by little. So what I will talk about is the latest round of health reforms in Mexico. To put it in picture of where this started, we had, of course, private sector delivery, high-end, expensive, that could cover the very wealthy. Then we have a very large Institute of Health, which is the one I headed, which covered all formal workers. Now, in theory, that should cover everyone. When you think of a developed country in Europe, the United States, everything, this is the way healthcare is given. And that's the way this was done in the 1950s. And that covers about 70 million Mexicans. There is a small institute that does the same for public servants that covers another 10 million. But then the problem that Mexico was not able to address is, how do you provide service? The people, an informal job. Now, in theory, the way looks. So the challenge in Mexico was, how do we get healthcare, effective healthcare, to everyone? The mandate is in the Constitution. When I was speaking to Sandhya, she said, well, how do people demand it? Well, in Mexico, everybody demanded healthcare, and the legal mandate was to provide universal healthcare. And we had the health ministry had a network of hospitals and primary care centers that provided health to the uninsured. But the problem was the quality, the effectiveness, and how opportunistic this was. What happened as the country grew, as my colleague from Turkey said, there were a number of issues that came together. We changed our health transition from infectious diseases to more to diabetes and cancers and degenerative diseases. So that put an enormous amount of pressure on the system. So whether you could go to the hospital or not, if you have an infectious disease, you get an antibiotic or something, and and it's easier to get fixed. When you have diabetes, you need a real healthcare system, and this provided the demand for a real, I wouldn't say a real reform, but a further reform, another step in the reform that would provide effective healthcare for the uninsured. And that's, I would say the last big round of, and we created something called the Seguro Popular, which is the popular insurance. And the idea was to provide effective healthcare, albeit limited, to everyone. Now, this is a problem because then you're providing the same services to different types of people. How do they auto-select? How do they know where to go to the right hospitals, etc.? So this was no small challenge to try to tell everyone what they had to do. But we did manage to ingrain the fact that it was a right. and that everybody had a right to healthcare. So you could go to the hospital where you had a right. What are some of the things that I think went well, and what are some of the things that did not go well? Healthcare expenditures increased, coverage increased, average quality increased. What were some of the things that did not go well? Well, now we have, two very large healthcare networks. One is the National Health Institute, National Social Security and Health Institute, which has a national coverage. And then you have the Seguro Popular. And this is an interesting political economy as well, because it is funded mostly by the federal government, but the funds are transferred to the states, and the states manage their own healthcare. So this is important because the point was, in theory, was to separate financing from health provision. And one of the issues that has not been talked about in this discussion, and I think it's crucial for the political economy as well, is in order to improve your healthcare, I would say, you can centrally fund, but provision has to be decentralized. You can do it publicly or privately so that there's competition and that citizens can vote with their feet and go to the health facility that is best served their needs. That is we're in the middle of a transition in Mexico. So I'll stop there, coming back to the original point. The political economy has two parts. It's not only the citizens and the states. The health institutions have their own political economy, and they have their own political power. The Health Institute, the Health and Social Security Institute has 500,000 health workers. El Seguro Popular has about 200,000. So they themselves create a political mass that also push for reforms. So with that, I will stop. I again apologize for the technical difficulties, but I'm glad I managed to say a few words. Thank you.
Thank you. Thank you so much. That was very, very helpful. And in fact, you touched upon, can I be heard? Louise, is it clear? Okay.
Yes.
So you touched upon the very critical issue of federalism. And I wanted to place that question, Nachiket, to you, and maybe Yamini can come in as well, because I know you both worked on it. That given India's federal structure and just building on what we just heard from José Antonio, why we know that health is a state subject, but there are roles played by the center and played by the states. Is it that the architecture of our health delivery as well as our fiscal flows somehow impeding
Sandhya, I think I maybe should take over here. You're breaking up a lot.
Incentives to states to take a stronger role? And how might these be changed? What are the kind of interventions that are greater autonomy and one could to be able to focus more on health? Nachiket, to begin with you, and then Yamini. Oh dear. Okay. Is my question clear?
Didn't quite get everything, Sandhya.
Sorry,
but,
can you not hear me?
Let me, because we are out of time, I want to be sure that, we do get some of these conversations in. I want to benefit from the presence of our three very eminent speakers here. We may not get them back again together. I'm always here. Clearly, the state has to play, in my view, a stronger role. One of the issues that I think we have faced, and I'd be keen to hear from Dr. José how they dealt with it, is that while in theory we have a federal structure, it's the Bihar health systems design that has been exported to the whole country. So we have taken the lowest common denominator and we have said everybody must follow that. There isn't a single health state that is following its own mandate. So, my favorite example is Kerala has 100% institutional delivery. It does not need to incentivize women to deliver babies in a health center. It needs to keep that money aside to deal with high suicide mortality and mental health problems. Yet, since Bihar doesn't have a mental health program, Kerala doesn't have one. But both have a program of incentives. I don't know if I could turn to Dr. José to see how the states were persuaded. In some ways, it's like a child. The child has grown up. Now you say to the child, well, do your thing. How does that actually happen?
Well, it's very difficult. I don't know if you can hear me, but it's very difficult. And you have to apply rules, and you have to create. Yes, can you hear me now?
Yes.
I can hear you well.
Yeah, we can hear you now, sir.
I was saying, thank you. I was saying that it's very difficult to do, and there are a couple of rules. One is in the case Mexico was done is you had to you were giving a capita for every person you enrolled in your system, but you had to enroll them, and that meant there was a series of requirements that had to happen. It wasn't just signing up somebody's name. You had to sign their name, they had to fulfill requirements, they had to be sure to be, Mexico has had a good vaccination program for decades. So the vaccination one worked, but it had to be systematized. And we created a regulatory entity, which is something that also has not been talked about, which is not the Ministry of Health, not the provider, but a regulator. And the regulator also has to, tries to certify that the health care is actually given within certain rules. So I'm making this up, but you're supposed to have all the children vaccinated, and there's a regulator who supervises that you actually vaccinated. You are supposed to provide 3 or 4 visits to a mother who is expecting. You go in and you try to supervise how this works. Now, all of this becomes very complicated if you don't have an electronic system so that you can have electronic records, how you do the reporting. So it's conceptually, I think the hard thing about health is that it's easy to talk about it from 40,000 feet up in the air. But once you get down to the nitty-gritty, it's hard to have a record of everybody who got a vaccine. It's hard to have a record of people visiting their doctors every 6 months. It's hard to have all of these records, and it's hard to make sure, for instance, we provide medicines as well. If you it's hard to make sure you have all the medicines in place so that you can provide the prescriptions. So the the easy answer to your question is it's hard, and you have to work on it. But an additional ingredient that you need on all of this that we have talked about is a regulator. And this provides the latest thing, I think, which is this transition so that eventually you can have public financing with private provisioning or public-private provisioning at the same time, and they can compete. And some other countries in the region, in Latin America, have done a very good job, notably Chile and Colombia have done a good job at mixing this model that is more efficient. Because the health institutes, the public health institutes, tend to have high administrative costs and inefficiencies, etc.
Nachiket, would you like to come back?
No, why don't I turn it over back to you, Louise, to see if there are other questions, because we have 15 minutes and I want to be sure that we get the most juice out of our deep experts. We can do another one with me talking.
I was going to take Yes, I was going to pose Sandhya's question for her because I think she's suffering from her poor internet connection. So this question I'll pose to in fact, all of the panelists. All of you in different ways have spoken about the importance of contextual factors alongside the more narrow political determinants that focus on health. And to some extent, especially in the way that you depicted the scenario in Turkey, Rifat, in the early 2000s, there was a confluence of factors that drew attention to very inequitable health outcomes, a connection between health and poverty, issues which are at the forefront of the health problem in India, if you like, at the moment. Why is a kind of similar context in India not driving the kind of political traction that we've seen in other countries? And why is it that human capital development and particularly investment in health and education as well, but we'll focus on health here, why is it that human capital development is not kind of clearly seen as a key variable in India's growth model? And I think if I might add a little on to Sandhya's questions as well there, the other big difference between India today and Turkey in the early 2000s, or India indeed in the early 2000s, is that rather than entering into a period of high growth, we're in a phase of fiscal contraction and continued pressures on the overall rates of economic growth. So what does that do for the political demands for health? Yamini, if I might come to you first, and then I'll invite anyone else who'd like to comment.
Well, I'm actually really keen to hear from the others, so I wouldn't say too much. I think I really do think part of the challenge is about state capacity. I think that the average citizen's experience in the public health system itself is a sort of reminder that the system is so broken that people actually don't see the state as a provider of health. They see other actors as providers of health. One of the consequences of economic growth from the 1990s and the sort of expansion to a degree of the private sector and its entry into health was that the elites exited entirely from the state system and kept themselves firmly in the private sector. And you don't need to look very far. The CGHS, the central government's health insurance for elite government, have an empaneled network of some of the biggest private hospitals, and actually most, even in COVID, if you just take a list of where did politicians go, a very large number ended up in private hospitals and fewer ended up in the All India Institute of Medical Sciences, which remains still today one of the premier institutions and premier hospitals in the country. On the other hand, if you look at the lower end of the income spectrum, most of the poor seek health outside of the public system. They usually go to the informal providers, and when they do enter into the government system, they encounter a system so broken and one that treats them in ways that don't actually build their trust, that they actually seek private health where they can afford it rather than seek public health. So it isn't, I'm not saying this to make the argument that that the state should exit. It's not that's not the argument at all. It is that the state thus far has not demonstrated its capability of providing health, and people have found alternative sources of where they go to seek health. And I think part of the challenge here is that for politicians and for bureaucrats, there are no clear ways in which they have available pathways to actually build the capability of the health system. It is so deeply broken that you have to go from the ground up. And because we don't have good, quick answers to that, the response always is actually to look at the potential private sector alternatives to the public health system. And we fail to understand that actually a health system is many systems. It's a public, it's a private, and a regulatory architecture, all of which have to work simultaneously. And you have to believe in the state's capability to do this before you, and therefore start investing in them. So what citizens ask of their politicians of health is usually access into the system. So, we've had this conversation even within the Lancet group, where, politicians will say, it's not like we are not actively doing a lot on health, but what is it that we're doing? We're trying to get hospital admissions. We're trying to find doctors for people. It's those transaction intensive parts. It's not systems building. When politicians or policymakers and bureaucrats are looking to try and strengthen the health system, that long, hard slog of taking a system that has been caught in a low-level equilibrium, and we're seeing this a lot. I've been studying the education system very closely, and I see this exactly in the same way. Shifting a low equilibrium system to a high-performing one requires a whole set of things to function together. We don't have any clear answers. And we have lost many years of not or particularly over the last decade or so, of not enough experimentation and innovation. And I think it's in that context that investments are not made, and therefore demand doesn't come, and it falls off the political agenda.
Thanks, Yamini. Rifat or Viroj, would you like to come in here?
Yeah, I think this is an important issue. I'm sure Viroj would like to comment as well. I think one has to be pragmatic. Each context is very different. And in my view, providing entitlement will create a problem, because you have to supply the service to citizens to meet their expectations. And in a situation like this, all the assets of the country must be used. Now, some of the most successful, in some settings, if there's state capacity, then the state could provide the services. In Turkey, both public and private sector assets were used when scaling up the services. In other settings, there will be big investment and scale up of purely state assets if there's a capacity, competence, and capability. In others, there could be a mix. In others, actually, such as the national health system, in England, for example, the very successful part of NHS is primary healthcare and family physicians. Family physicians are independent contractors. They're not state employees. So one has to use different instruments and approaches to ensure effective coverage that is responsive to citizens' needs. So maybe rather than, if the state is not able to act as a competent provider of services, maybe the state capacity could be developed to make it an effective regulator, an effective commissioner of services. I'm using the word commissioner as opposed to purchaser because it involves some strategic thinking rather than just a transactional payment of services. So I think one has to experiment with different models and learn from this. But what's important is to scale up and demonstrate benefits to citizens to create this demand for services. In our work in Turkey, what we're able to show was that as primary healthcare services were scaled up, utilization of services were scaled up very rapidly. And something interesting happened. Initially, this was because accessibility had improved. But even though the citizens had the right to go to hospitals directly, access to primary care continued to increase because quality was an important factor in determining that, whereas the direct access to hospitals leveled off, even declined, primary care continued to rise because it was effective coverage that was responsive beyond just accessibility. This is why I think this investment monitoring and really understanding what is being provided and how the citizens are responding is so critically important.
May I just, am I audible now?
Yes.
Okay. Could I just, Dr. Viroj, if you're going to come in, it'll be great to hear your thoughts as well. Just building on what Rifat said and what Yamini said, how does the state view the importance of actually building human capital. Because what we heard each one of you say was that the governments were responding to a certain context of inequities in health access. And there was a need to address those inequities, whether people were demanding them or not. That's what I understood. Correct me if that's not right. That means there was a basic perception that this is something that needs to be addressed, and citizens of each of these countries need to build their human capital through better health, education, etc., etc. That is not clear in India that is the case. So just your thoughts on that. The whole
From our experience, we can conclude that the quality and health workforce competencies are the key social capital in the health system. In the past 4 decades, that gradually built up and shaped citizen trust, institutional trust to the health system, very much so in government health institution and less so in private. Unlike Mexico, you use a lot of private sector. Private sector in Thailand, if you do not regulate well, they just cheat you. They just circumvent all the regulation, etc. Therefore, if you contract private sector, you have to regulate very well. This is the case of your RSBY system in India, because you contract a lot of private, almost private sectors. Therefore, I think the trust is so critical, trust in health system, institutional trust, that you are trustworthy. Then the demand for health services is there. We have very high contraceptive preference, 80%, because they have trust in the health system. Immunization coverage is very high, hesitancy is very low, because we have a good AEFI system, etc.
Thank you. Jose, Antonio, something to add on that?
No, I mean, I think, as our experience from Thailand says, it plays a role. But I am a firm believer that public it leads to politics, whereas you keep the funding for the most needed, but you allow competition, and it could be competition among the different public.
You're also breaking up a lot, struggling to hear you. Okay, we are actually on time. We have a minute left. I'm tempted to ask each one for some very quick parting thoughts, and then for Louise to, I can't say summarize, but close the meeting. Some quick parting thoughts from everybody.
I'll go quickly. So inform and engage the citizens, and ensure that the services provider align with what they're expecting. Don't make this as a technocratic solution. This needs to be very much designed to meet the citizens' needs. They need to be engaged, they need to improve their literacy, and then you need to create that symbiosis, which will then create trust. But that requires not just entitlements on paper. Supply side needs to be really in place with high quality and highly responsive to citizens' needs with the appropriate accountability.
Perfect, thank you. Dr. Viroj, parting thoughts?
Quick thought. I think a trustworthy supply side is the key entry point for India. Maybe a trustworthy, reliable supply side, government, because government distribute throughout the country, whereby private sector go when the money is. Where there's no money, they don't go. Therefore, ensure equity. You have to have a government trust in government health institution as an entry point for USC.
Thank you. Jose Antonio?
Well, I will come back just to say that health reform is a various step event, and that one should build on what you have slowly but surely to try to change the institutions, because you can't go to the end without going through. It's a cliche, but it's absolutely true. We can't all have the UK's National Health Service overnight. So you have to build on what you have within your political constraints, your labor constraints, and your institutional constraints to get there.
Very well said. Thank you. Yamini?
Thank you. I think what we've learned from across the globe is very much that state capability and political determinants of health are actually intertwined, deeply intertwined. And so perhaps we need to be framing these questions together. I think a trustworthy supply side response is at the heart of what will build robust political demand, and that trustworthy supply side response comes through political will. So I don't think that politics is taken out of that at all. I also think, I wanted to very quickly say, I was skimming through some of the questions in the Q&A box, and various people referred to Kerala, Maharashtra. India is not one health system, it's many health systems, different state responses are different. But I do think that in each of those where things have worked relatively better are embedded exactly the same sets of lessons that we have learned from Mexico, from Turkey, from Thailand. So we also, of course, need to look at our states, and at no point is this conversation, especially because we talked about federalism, trying to suggest that India's health is one uniformly bad system. It's many somewhat bad systems caught in low equilibrium. And then it's many systems that perform somewhat better, but still have a long way to go. And therefore, the question of what does it take to convert our current health architecture into a high-performing, capable health system, or many health systems, is what we should be asking from an Indian perspective.
Absolutely. Very well said, Yamini. Thank you. Nachiket?
So I really enjoyed this discussion, and I want to quickly say one thing that I picked up from each of the speakers, just for me to reflect on. One, I think what Dr. Atun said is that building trust, because we are where we are. We can't magically transport ourselves to Switzerland. We are in India, we have what we have. Unleashing a reinforcing loop in which we do something well, whatever it is. Maybe that's a place to start. The second, which I like what Dr. Viroj said, which reflects my thinking, do your own thinking. Don't wait for the World Bank or somebody else to tell you, build your own wisdom, figure out what you want to do. And I think one point that Jose said, which I thought even Dr. Atun echoed, is that, use the assets you have. Okay, we don't have X, we can lament about that, but we have actually Y. It's a point Yamini made so well, right? Now, it's an important point that Dr. Viroj made, that if you are going to work with the private sector, you'd better know how to deal with it, right? Because it's not obvious, but it's not entirely obvious to me as well, that given where we are, that the status quo is giving us better outcomes. So to me, these were the three, kind of interesting ideas that I took away from these three eminent speakers. Just a wonderful session. I wish we had another hour and a half to really get into it, but I gained a lot. Thank you so much.
Thank you, Nachiket. I was thinking that in the real world, which is outside of the pandemic, this would have been at least a day-long conversation. But sadly, we are where we are. Louise, last word to you and closing thoughts.
Thank you, Sandhya, and thank you to all of our speakers. It was a wonderful discussion, despite all the challenges of doing this across continents on Zoom. I think if I were to pull out three key takeaways from the conversation, they would be as follows. I think, firstly, we've heard that political windows of opportunity for taking on difficult health sector reforms are the product of multiple conjunctural factors, and they come along rarely. So I think that was the first kind of real headline in thinking about this. The second, and which follows from that in a sense, is that the focus maybe ought to be more on supply side reforms as a means of building trust in capabilities, and that the voter demand, which I think we all agree as being so important for maintaining accountability and the perpetuation or longer term durability of reforms, that voter demand will follow on from the demonstration of capability. So that was the second key takeaway for me, the significance of the supply side. And I think the third key takeaway, which we've touched on a bit, but I think there's a lot more scope to dive in deeper, is the role and the shape of the state, especially in a mixed health system with a lot of private sector and community health work going on. So I think Jose made this point very well, which is that where, I think it was Jose, where you're in a low capacity equilibrium, it may be more important for the state to develop its role as a regulator than as a provider of health. And the other question, which we touched a little on, is the shape of the state. So the relevance and importance of thinking about federalism, the flow of financing for health, as well as the location for design and implementation of health reforms at a local level. There was much more in this, and I also want to acknowledge that there were a lot of questions that came in that we haven't been able to address, but I hope that this will be the first of many future conversations. So I do hope that you'll be able to carry on with us along that journey. So thank you. Goodbye for today.
Thank you very much. Thank you all. Thanks so much.